Welcome. My name's Thom. I'm coming from the University of Virginia in Charlottesville, and talk today is on a little bit of a niche topic, but if you're here, it's probably interesting or important to you. We've all heard a lot about the 2023 billing and coding changes and how they impact emergency medicine, right? That's sort of probably had some lectures, seen some slideshows on that, right? So this is going to be targeted at how does this impact point-of-care ultrasound billing specifically, and what does that mean for the point-of-care ultrasound enthusiast? Brief disclosure, I do a little bit of research and consulting work with an ultrasound manufacturer in Charlottesville, and some reimbursement work as well. And thanks to Todd Thomas, who's the president of one of these national coding groups, that helped me make sure everything on the slides makes sense and was valid and those kind of things. Okay. Save it all, plays 6 videos on a PowerPoint. It's working. Okay. So we get interested, we get excited by point-of-care ultrasound, right? Not because of things like billing, right? We get interested and excited about it because of how it expedites clinical care, improves patient safety, gets us closer to the correct diagnosis, which is, of course, the biggest job of an emergency physician is landing on that correct diagnosis. That's sort of why we get interested in point-of-care ultrasound, and that's where it gets its legs. But, there are other issues, right, that come up. Ultrasound machine hardware issues. We heard a little bit on cleaning and disinfection and how even if we don't want to pay attention to that, we're going to get roped into those meetings or we're going to find these probes taken away and those kind of things. And billing is a little bit similar, right? It's really hard to separate these two. In other words, if you don't have point-of-care ultrasound billing, it can limit the potential of a point-of-care ultrasound program. I'm sure plenty of folks in the room have gone forward with return on investment calculations for new ultrasound machine purchases, for workflow systems. Hey, that Butterfly Enterprise system looks cool, but it's a per year charge, so how are we going to make up for that, right? And so if we don't have billing, we lose a little bit of the force behind that, and that can have an impact on us, okay? I always say it's not a pot of gold. Nobody gets rich off of it, but it generally is enough to justify a program, to justify machine purchases, etc. So this is one of these charts you've probably seen. This is just a sort of a step back reminder, right? So most of the point-of-care ultrasound exams we do have an associated CPT code that can be applied, right? And so that can generally be billed separately, or historically can be billed separately in addition to the main E&M level, if you will, or the main ED chart CPT code, kind of like an intubation or a central line would. There's a potential for a professional fee reimbursement to the physician and the potential for a facility fee reimbursement to the hospital. All right. So pre-2023, how did it work? Okay, well, here is an example of an MDM grading grid, if you will, that a coder and biller would see when they're working up a chart. And I only bring it up, it's heavy, so I'll sort of highlight some things here. But just bringing it up because the ultrasound could, right, the point-of-care ultrasound could count towards chart complexity, both in data and in risk there. But the big difference is, of course, that the ultrasound could also be billed separately to the ED physician. So just because it was bumping your MDM and your chart complexity didn't mean you couldn't bill for it, right? In 2023, as I mentioned, you might have heard, right, some stuff changed, right? So we went from this sort of HPI, review of systems, physical exam, sort of bean counting game, if you will, to more of an MDM bean counting game, right? And there are good things and bad things to that shift, a lot of good things. I won't hit you too hard with this grid because I know nobody wants to look at this thing. I agree. But just a reminder, there are 3 components to that MDM grading, right? The complexity of problems addressed on the left-hand side, the data in the middle, and then the risk on the right-hand side. And the rule of thumb is to get to a certain chart level, you have to have 2 out of 3 of those categories covered, okay? So in other words, you have to have the complexity on the left-hand side plus the risk, the complexity plus the data for that chart level to get to that chart level. But let's make it easier on the eyes, right? So this is the data. This is where ultrasound has an impact, a potential impact, right? So we listed the data here. The difference between a 99284 chart and a 99285 is just whether or not you have 1 element of data versus 2 elements of data, right? And where the ultrasound potentially plays a role is right here, this independent interpretation of test, right? So in 2023 and onwards, you sort of have to choose your own adventure. You have to make a choice, okay? You can't do both. Either you use the ultrasound in the MDM grading grid to increase chart complexity, or you bill it separately, but you can't do both, So you have to choose. So what do you choose, and what does that do for an ultrasound program? So these are just tables with some common point-of-care ultrasound exams. We've got the work RVUs here. Keeping in mind that's not the total RVU, but the work RVU is kind of the meat of the RVU, if you will. So we're seeing that there. And I put this up both for orientation to the lecture, but also just to point out that generally, if you're bumping a chart level, right, you're gaining more work RVUs than if you're billing the ultrasound separately. Okay, so that everybody sees that. Okay, so we're going to do two cases, and these are not meant to be holistic cases, and please don't judge the clinical decision making of the case, right? This is just meant to give you examples. So 40-year-old who comes in with thigh swelling, right, gradually worsening, perhaps have been on a long trip or a plane flight or something really easy, right? And so we've got a MDM there, limited exam, MDM up there. Things to point out, differential includes DVT, right, muscle spasm. The physician in this case documents an independent interpretation, an independent historian, sorry. So the husband talks about how there was a surgery a few years ago. The physician documents review of an external note, there was a workup for a DVT at that time, and then there's a plan, okay? So we're going to bring back this grid briefly, but it's an ultrasound lecture, so we're going to continue to include ultrasound clips, okay? So that's the common femoral vein GSV junction, right? We're seeing good compression there, so no DVT or blood clot right at that spot. So if we grade this chart, how does it shake out? Well, the first category, complexity, right, and I'm sorry, so disposition, ultrasound's negative, case discussed with a PCP, come up with a plan, and sort of moving forward. So how does this get graded? Well, we get a high level of risk, a level 5 level of complexity. When we've got a differential that is life-threatening, like a DVT, the coders and billers tend to assign that, and they're allowed to assign that, even if it doesn't turn out to be the pathology at hand, right? So that goes into documenting your differential and what you're worried about and those things. We do have a review of a prior note. We do have an independent historian. But if you notice, you need 3, right, for that category 1 in data, if everybody sees that. We've got 2, right? So now we've got a decision. We've met level 5 chart criteria for complexity. We didn't meet it for risk because we're not giving any fancy drugs or doing surgery or those kind of things, right? We've got 2 elements here. We need at least another one, right? Or we're going to have to use the ultrasound. But keep in mind, we did talk to the PCP, right? So we get category 3. So we've got category 3. We've almost got category 1. Well, we don't have it. So we've got to decide, right? Do we bill the DVT separately, or do we use it in the MDM, right? So let's see how that works out with math real quick, right? So doing the math for you, don't worry. So those are the differences, right? So if you're a biller coder or an EM physician, right, interested in getting reimbursed for the work you do, you might choose this one, right? So what happened there? The ultrasound was not billed. It wasn't coded. It's not necessarily going to show up on a return on investment sheet, right? But it's going to be used to drive MDM complexity. Let's look at this case. So here we've got chest pain. Not a lot there. Chest pain, viral URI, really limited the exam to try to limit the words on the slide, of course. Differential here, pericarditis, acute coronary syndrome, pulmonary embolism, so some potentially worrisome things. We're going to get an EKG, a chest x-ray, bedside echo, D-dimer. And here we've got a peristernal long and a peristernal short axis of the heart, looking fairly healthy or fairly normal. We've got that interpretation there. We did do several lab tests, right? We've got a radiologist interpretation that's there, so a negative chest x-ray. And then we see what the ED physician documented here. The EKG is negative, the laboratory work's unremarkable, bedside TEs with no effusion, chest x-ray negative, presumed pericarditis, and discharging home. So how does this one shake out? So we again get that high level for complexity because we've got some life-threatening things on our differential. We come over to data, right, and we've got several tests. We've got 4 CBC, CMP, troponin, and D-dimer, so we're going to make it on category 1, and now we're stuck again, right? Either we include the echo in category 2 and get the level 5 chart, or we get bumped over to a level 4 chart and bill the ultrasound separately. So how does that look in this case? A little bit like this, right? So there's an advantage there to billing to using the ultrasound in the MDM. So this question, right? Good question. So having the point-of-care ultrasound rolled into the MDM isn't necessarily a bad thing, right? We're increasing revenue. We're still getting paid for the work and the ultrasound exams we do. But there are two sides to that story. The first side, of course, is that before 2023, we were doing that anyway. You could increase the chart complexity and bill, right? Now we can only sort of choose one, if you will. And of course, making a return on investment calculation based on the charts that were bumped versus not, that's a lot more gray, right? That's a lot more difficult and nuanced than just looking at what was billed and what the reimbursement was for those exams. And you know, the most important point, of course, is that if you have enough stuff that you've done in that ED visit, but you just didn't document it, and if you had documented it, it would have meant that the point-of-care ultrasound didn't need to be put in the MDM, then that's the best answer, right? Because then you're capturing all the maximal revenue, you're you know, maintaining the program, et cetera. So let's look at this, these cases again. So this is that DVT case. This hasn't changed, right? We reviewed that external note from the prior PCP visit. We had the independent historian, right? We talked with the PCP. So in this case, if we had documented one more external note, we would have made it to level 5 without needing the ultrasound in the MDM. The DVT ultrasound could have been billed separately. We'd have both, right? So that would be the ideal situation. And chances are, if you looked at one note, you might have looked at another one, and it was just an absence of the documentation, right? So having a little bit of working knowledge here can help you know when things are going to work and when things aren't. This is that chest pain case. Again, for simplicity, we've got a high complexity there. We've got plenty of things in category 1. If we had added an independent interpretation, right, of the chest x-ray. So we did a chest x-ray. The radiologist read it, right? We didn't. If we add an independent interpretation, that's going to fulfill category 2, and all of a sudden we're good, right? We no longer need that point-of-care ultrasound in that slot, and we can bill it separately. The other option, of course, which is potentially underutilized, although you don't want to overutilize it, is this decision regarding hospitalization, right, and how we use that. If we had documented one of those, we would have gotten it for complexity, gotten it for risk, remember 2 out of 3, and we would have made it, right? We wouldn't have needed the ultrasound to go into the data in the MDM. It could have been billed separately. You know, when you think about decision regarding hospitalization, everybody has slightly different takes on it, but chest pain is a good one for that in my book, right? Because we all sort of go through an algorithm. Are we discharging? Are we admitting, right? And that algorithm often takes into account risk factors and heart score and concerning story. And so you're doing that anyway, but by documenting it right, you achieve that. In this case, you save the point-of-care ultrasound from being rolled into the MDM, so to speak. Okay, so strategies to avoid needing the point-of-care ultrasound for MDM complexity. You know, not much with complexity, right? So you know, here, this is just a reminder that the final diagnosis doesn't denote the complexity of the chart, right? It's other things that you considered, it's presenting symptoms, etc. So when you're considering and testing for life-threatening things, potentially worth talking about. Data I'm going to come back to on the next slide because that's the big one, right? And then risk is just decision regarding hospitalization. There's a few other things in the risk category, but a lot of those were sort of stuck. There's not many things that we can just change with documentation. You sort of would have to do other things. Okay, so let's look at these, right? So data. So independent interpretation of other tests is a great one to, if you will, protect the point-of-care ultrasound from needing to be rolled into the MDM. As soon as there's something in there, right, independent interpretation of X-ray, CT, right, EKG is going to come next, right, then there's no longer any reason for that point-of-care ultrasound to be, you know, not to be dramatic, but to be sacrificed into the MDM because you don't need it. You've already gotten there. That point-of-care ultrasound does nothing for you in the MDM anymore and can be used as a separate billable procedure. Question? That is EKG on number 3. Yeah. Yep. So what do I mean by sacrifice the EKG? You know, it's sort of, you know, don't mean to, you know, sort of negate the EKG, right? Those are important, but the billing on those, the work RVUs on those is roughly 1/3 of your point-of-care ultrasound. So if you have to choose what's going to be rolled into your independent interpretation, an EKG or a point-of-care ultrasound, you want to toss the EKG, right? Because nobody sort of needs that for return on investment calculations, but more importantly, you're going to get more revenue if you build a POCUS and sacrifice the EKG. Okay, so these are all things to consider. The biggest risk I think I see is, you know, and this is where having a relationship with your billers and coders is so important. I think one of the big risks here is if somebody sort of looks at it and says, well, hey, the point-of-care ultrasound billing is actually reducing our E&M level complexity because we're billing for all these point-of-care ultrasounds. If we just rolled them into independent interpretations, we'd come out on top. Yes, we'd lose a few point-of-care ultrasounds, but overall, we'd be winning, right? So that we don't want to happen, because then all of a sudden we're losing the ability to bill independently for point-of-care ultrasound, and that has implications for our programs. So if you were meeting with billers and coders, you could have a few strategies. Okay, strategy number one might say, hey, let's bill the point-of-care ultrasound on all patients with an independent interpretation of another test, because there's no case, 0% of cases, where you then need the ultrasound in the MDM, right? So that would be strategy one. You know, above strategy one would be if you had a really good relationship with your billers and coders and could sort of establish the understanding that, hey, if you need the ultrasound in the MDM, put it in the MDM. But if there's anything else you can put in there, please do that and save the point-of-care ultrasound and bill that separately, right? That's the gold standard. But if you need it simpler, strategy one is a good one. Strategy two is okay as well. Most admitted patients are going to meet level 5 criteria without needing anything else. And without needing the ultrasound, so that would be fair. And then a third one would be the EKG. All right, so those would all be potential options. Okay, we're going to finish with this, and this is sort of, it sounds, you know, seemingly frustrating, right? If you're somebody who sort of, you know, you get signed out on somebody and there's a radiology renal ultrasound ordered and your heart dies a little bit because they're just looking for hydronephrosis, and it's like, oh gosh, that's just a tragedy on so you just sort of sigh, right? You bow your head a little bit and you just sort of go to your happy place for 5 seconds and then continue sign outs. Is that just me, or is it some other people? All right, so if that's you, right, this will grind your gears just a little bit for a second, but this is a real real case, right? And I'm just going to put it all out. So there are 2 visits. These are both to our ED. The first one, right, the ED physician number 1. You can see the work up there, labs, radiology, renal ultrasound, establishes the diagnosis of renal stone discharges. Patient bounces back like kidney stones do, not a big deal, right? This time a point-of-care ultrasound is done by ED physician number 2. You know, we're going to be more apt to find things like UVJ stones, right? So now we can sort of know the size, location of the stone, which is just extra information, and that's helpful. And then you look at the billing, right? And both visits were billed the same. In other words, ED physician number 1 got the exact same professional revenue as ED physician number 2, even though ED physician number 1 didn't do the ultrasound and ED physician number 2 did, right? So how did that happen? Well, it has to do with this independent interpretation thing, right? So in the first case, ED physician number 2 has performed the point-of-care ultrasound. They're going to document the interpretation. And then if it's a case where you need the ultrasound in the MDM, right? And I will say most cases don't, especially if you're thinking about this issue, right? But if it's a case that needs the ultrasound in the MDM, you're left with the choose your own adventure, and you sort of are going to fall out on billing the 99285 and not billing the ultrasound separately, okay? Now, how does ED physician number 1 get there? Well, they ordered the radiology ultrasound. They sat back. They didn't do anything. They looked at an image or two on that ultrasound, put in an independent interpretation of the radiology ultrasound, and now they've got the same credit on the MDM grid, right? Tricky, right? Importantly, this is a minority of cases. You know, I think the cases at risk for this are the ones where an ultrasound is the only thing done, or an ultrasound and some lab tests are the only things done, right? I think those are the highest risk for this. And I certainly would not sort of put this up here and say that any of this, right, negates the innate value of point-of-care ultrasound, which goes a lot farther than billing, right? There's a lot more to it than billing, and a lot more of a benefit to the patient to billing. So I don't want to sort of put this up and say this is super bad, but I just want people to be aware this is how the math can work, okay? So with that, I will take questions. James. Question is a plant. No, you're absolutely right. And certainly that incentive exists in 2022 and earlier, and in 2023. The more tests you order, the more stuff you do, the more likely you are to admit the patient, the higher the reimbursement gets, right? So it's a perverse incentive either way. But you're absolutely right. You know, yeah, you don't want to incentivize people to just chase the greenbacks. I think the theme of this is when you've done the work, when you've talked to a PCP, when you've ordered a chest x-ray already and looked at it, you might as well get credit for that work, right? It's not order extra stuff to try to game the system, but it is have knowledge of where things are applied and how they're applied. And if you talk to that PCP, put it in your documentation. It probably benefits you clinically, medical legally, and from a billing perspective. But I appreciate that risk. You know, certainly you don't want to, you know, the worst part about this whole grid, right? Everybody saw, you know, intravenous opioids on the risk category in level 5. You give somebody Toradol, it's a level 4 chart. You give morphine, it's a level 5. That's probably the worst thing that comes out of this, right? Yeah. 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 Yeah, it totally depends on your coding and billing conversations as well as how you document ultrasound. So that could go either way. You know, our example, right, so we use Epic procedure notes and PACS and that kind of thing. So in our case, if they need the ultrasound in the MDM, they're going to use it in the MDM and they're not going to bill it. But I'm not going to know that, right, when I'm doing it. Okay, it's going to look exactly the same. We're going to ask our docs to put in our ultrasounds exactly the same, use the same workflow. We still want to QA them, give feedback, those kind of things. Yeah, so it'll look the same for us. So it does depend on your coder and biller and how that works out. And, you know, gold standard might be to have your ultrasound note somewhere in the chart, your official thing, and then you can always talk about it in the MDM. And if you have a good setup, then hopefully your coder and biller will still bill the point-of-care ultrasound if they can, right? And on the critically ill patients who are getting a lot of stuff, they really should be able to, right? Unless you're really not documenting what you're doing. Yeah. I don't think the ultrasound, time spent during the ultrasound can be applied to critical care time. Could be wrong about that, but I don't think you can apply it to critical care time. So on those level 6 charts, your critical care charts should be able to be billed separately. Yeah. Yeah. Mm-hmm. Yep. Yeah. But yeah, but you want to know what your coder and biller is going to do. You know, you want to know if you're one of the shops where they're switching from doing any point-of-care ultrasound billing to just saying, hey, let's make this easy. Let's roll them all into the MDM anyway. We've lost a few because we're doing lower E&M levels by billing all these point-of-care ultrasounds. We don't want to make it complex. We want to make it easy. All going into the MDM, right? That's what you want to avoid, right? Because it's unnecessary. Okay, there are other strategies that'll work well. And you know, again, leaving revenue on the table and also putting a big hammer to the point-of-care ultrasound program. But yeah. Yeah. Yeah, again, conversations with coders and billers, but yes, you could officially use one of those, right? If, one of those to fulfill the independent interpretation and then bill out the other two separately. Now, whether you have a coder biller that's going to get that nuanced with it, I don't know. You know, hats off to you if you do, but that's getting pretty nuanced. But officially, that would follow the rule of the law. Yes. Yeah. Yeah, it's a good question. The requirements are going to be less than a separately billable CPT code. So the separately billable CPT code requirements, you know, things, indications, medical necessity, findings, interpretation, right? You lose all of that and you just get into providing a freehand, you know, cardiac echo with no pericardial effusion. Best practice is still going to be to save the images. Don't know that that's entirely necessary to get that independent interpretation line. Because you don't fall into that 7 years of Medicare required to save the image, those kind of things. But obviously you don't want to say that because then here come the ghost scans and stuff like that, right? So, Jason. Yeah. Well, they can add up. So you need 3 somewhere in there. So that could be a CBC, a CMP, and an external record, right? Or it could be 3 external records, and that would fulfill it. Yeah. Yep. Exactly. Yep. So it can be a bunch of independent interpretations, a bunch of external notes, a bunch of labs. Yep. And then in the back, I think. Okay, I'm getting back to a zoomed-in version of that. I'm just not doing it quickly at all. Okay. Okay, so independent interpretation of a test performed by another physician, other qualified healthcare professional not separately reported. Say that again, sorry. Yeah. 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 I think it's a game of language and the particular language the AMA used in this chart. So another way to say this would be you can get an independent interpretation of test if you have an independent interpretation of a test performed by another physician or an independent interpretation of your own test that's not separately reported. Right, so it's one of those two. Yeah, I'm not sure. I think I think the wording here is a little bit poor, but not separately reported is supposed to be there to indicate that it could be the physician who could be you. It's just not separately reported, so it can count there. Yeah. Yeah, it's a really good question, and no, it doesn't, right? The biller coder is not going to know if you put that independent interpretation in after you looked at the radiologist interpretation or before, right? And that part probably doesn't matter, both from a billing and whatever else standpoint, right? If you actually look at the images, you can put your independent interpretation. You could disagree with the radiologist, you could agree with the radiologist, but it doesn't have to be before or after. Yeah. And then yeah. 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 Yeah, both are great questions, and no, we don't bill for rhythm strips telemetry, although we could, and that, because it has a CPT code associated with it, if you're doing that, that could fulfill that independent interpretation, and you could leave the point-of-care ultrasound for separate billing. To your second point, it depends. The facility fee conversation is very interesting. If they're 2 separate groups, and they're entirely separate, right, like you've got a contract management group and a big hospital chain, then you could still bill a facility fee because there's 2 separate groups there. My understanding is once you start melding that and the physician is an employee of the hospital, then it becomes a lot harder to do that, and you may get those rejected or that may not work. I don't know that anybody totally knows the answer to that, to be completely honest, having had some conversations about it. But if it's a totally different physician group from the hospital, then the hospital's still going to be billing technical fees, and it's probably going to be fine. If it's melded together and you're an employee, then you may find it doesn't work. But I don't know that we know that for sure. All right. Great. Well, thanks for your attention, everybody. Yeah.